now met each other. But just in case, I thought it might make a bit of sense, just do a very, very quick introduction. I think everybody else, hopefully everybody knows where everybody is, but just so they know. So I'm Gordon Borgstrom. I'm with the BC Rural Centre. I live in Kamloops, which is on the traditional territory of the Secwepemc people. And so maybe with that, I'll sort of go around on the box for those I can see and turn it over to you, Marion.
So I'm Marion Oxney. I'm the ED of Pender Island, not Pender Harbor Healthcare Society, although we do share mail from time to time.
Thank you. And Dr. Markham.
Thanks, Gord. Hi, I'm Ray Markham, a rural GP from in the village of Vermont, which is on the Kakiletinay and some territory, part of the team at the Rural Coordination Centre in BC.
Thank you, Ray. Jane.
Jane Osborne, queer senior on Snuneymuxw, Naus, and Stubinus traditional territories, working on the community side of adult guardianship with BCCRN and on the board of the BC Rural Health Network, which is coming up, in a half hour. So great to see you all.
Exactly. Thanks, Jane. Appreciate you doing that. Sorry, double booked. Luella? Oh, sorry, you're muted.
So this is my first meeting, I'm pretty sure. I've been trying to make it for a few months now. So I'm Luella from Arrow Lakes Better at Home program with ASLCS, United Way, and program coordinator, and looking forward to learning more about what this is all about.
Thank you, Luella. Appreciate it. Mark?
Hi, everybody. Mark Peltry. I'm the CEO of the Institute for Health System Transformation and Sustainability, and we're based in BC, but I'm working from the Coast Salish area of the Lower Mainland.
Okay. Thanks very much, Mark. Lorraine.
Good day, everyone. Lorraine Gerwing, Northern Rockies Regional Municipality Councillor, so recently re-elected for my third term. Coming to you from Fort Nelson, traditional territories of Fort Nelson First Nations.
Thanks very much, Lorraine. Nice to see you again. And Shannon, I'm not sure. I'll turn over to Shannon
from
first.
Pacific BlueCross. Yes. Go ahead, Shannon.
Yes. Hi, everyone. This is my first meeting as well. Leza invited me to join you all today. I'm with Pacific BlueCross and I work in the product and innovation departments. And so interested to hear and always gather insights around our the needs of the populations that we serve and that we design our products and benefit plans for. So coming today to observe and listen. And I'm in the territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations.
Thank you very much, Shannon. Leza?
And hi, my name is Leza Muir, and I'm the Chief Operating Officer at Pacific BlueCross. And similar to Shannon, I'm also coming to you from the unceded traditional territories of the Coast Salish peoples, specifically the Squamish, the Musqueam, and the Tsleil-Waututh First Nations.
Exactly. Thanks, Leza. And Blay.
Hi, everybody. Blay Hansen, health policy analyst here at Métis Nation, British Columbia, calling in from the headquarters here in what is now known as Surrey, beautiful Coast Salish territory. Well, beautiful and gray and rainy. But I'm new to BC, and I can live with this because over in Treaty 6 territory in Edmonton, it's not so nice. So happy to be here. Very happy to be here. And this is my first meeting as well. So I'm looking forward to getting to know all of you and moving this forward.
Yeah, thanks very much, Blay. And I really appreciate you making the time to join us too. Really appreciate that. A very informal group for those of you that are joining us for the first time. As I mentioned, what we're trying to do is keep most of the meetings, if we can, to an hour and 15 minutes at the absolute most. We fully understand, and there's cases such as Jane, where she's double booked, so we'll have to leave us early in order to go join yet another Zoom call. But today, what we were thinking after our last meeting, we thought it might be to have a bit of an interesting discussion. Leza is part of our committee, is to talk sort of about private healthcare insurance, and sort of from the perspective of those of us that do live in rural areas, sort of some issues around that. And then we thought we would just open up the discussion generally as well about what else might be on folks' minds. So with that, I'll turn it over to Leza.
Thank you, Gord. Appreciate it. As Gord asked me if I would be willing to do a presentation on our private health benefits, and I'm hoping I've only got a few slides. There's not very many, and I wanted just to give you a little bit of an overview of the types of benefits that we do offer to plan sponsors, and those are plan sponsors of any size, and we can customize them as well, depending on the need of the plan sponsor, the employer. So I'm going to share my screen, and Shannon is going to hopefully step in and help me on anything that I miss. So I'm just hoping I've got the right. Okay, so just making sure, can everybody see the full screen up? So it should be a full title screen. Does it look okay? Okay, good. So first of all, for those of you that don't know, Pacific Blue Cross, we are a not-for-profit health benefits or an insurance provider. We are based here in BC. We cover about 1.6 million people, or about 1 in 3 British Columbians today. And we provide health, dental, and life and disability coverage. And our mission is to improve the health and well-being of British Columbians. And as well, we also have a foundation, and we support a number of different communities throughout on various charitable initiatives. Let's make sure, oops, there we go, oops. I'm not going to spend a lot of time on this, but this was something I learned when I was doing research for this in terms of rural communities. So this comes out of the census population. So a rural area is defined to have less than 1,000 people and a density of fewer than 400 people per square kilometer. And we actually have 635,000, or 12% of our population is actually living in rural areas. Small towns actually have less than 30,000 residents, and BC has 600,000, or 12% of the population living in small towns. So that's a pretty significant. That's about 1/5 of the province that is actually in, the rural and small town arena, which has a very different level of access to care, I'm going to say, than those that are in the urban centers. So what do we do? Pacific Blue Cross is a private insurer, and what I'm really trying to show you is the product lines that we cover. So in terms of our health benefits, which we call our core benefits in our health plans, we cover prescription drugs, we cover vision care products, we cover life and accidental death and dismemberment, we cover hearing aids, we cover respirators and oxygen if a member needs it, medical equipment, which is a whole range of medical equipment. It could be hospital beds, wheelchairs, aids for daily living, lifts, braces, if people need braces. It's CPAP machines, a whole bunch of different categories of things fall in that category. We cover orthopedic shoes and orthotics if you need them. We also have a virtual care offering, and I'll tell you a little bit more about that. We also have generally what we call out of province or travel medical. So if you're traveling outside of the province or outside of the country, we do cover emergency care if you have an emergent situation. In the paramedical category, we cover speech pathology, massage therapy, physiotherapy, acupuncture, naturopathy, podiatry, dietitians, all the psychological services and chiropractic services. Some of our plans covered registered clinical counselors, and many of our plans now also cover online cognitive behavior therapy as well for the mental health. Now we do have optional benefits. So those are what we sort of consider core. What I mean by that is if you're an employer in a small town or a rural area, generally it's those core benefits, and you can pick your levels of paramedicals that you would get, but they can also add on optional benefits too, to be on top of that. Critical illness coverage, and we have a list of disease states, and then the funding that we would provide should you get that disease to basically give you some financial assistance while you're traversing you're getting well from that disease state. Dental care, which I think everybody's quite familiar with dental care coverage, long-term disability, and short-term disability. And that's going, if generally, if someone is disabled from work, we will cover a percentage of their normal income on that. And we also offer health spending accounts. And generally those are, the employer will put in a segment of money. The employee can then use that money to purchase any health-related expense that is available through the medical expense tax credit system to be deducted under your plans. So I sort of thrown a lot at you. I'm happy to answer any questions. If anyone has any questions anytime, just let me know. So when I'm going to talk a little bit about those benefits and what they include. So when we offer these benefits, and again, we are aware that not everybody is in an urban setting. We realize that they could be in small towns. So we offer a lot of different tools and channels for people to be able to access those benefits or utilize them. We do have a mobile app or through a web portal. Any of our members can sign in. They can find out whatever coverage they have, how much they've used. They can actually submit their claims online. So they never have to use the mail system or go to a post office. They can actually submit the majority of their claims in an online ability. And they could also look up claims that have been previously paid, not only those that they've submitted themselves, but those that other healthcare providers have submitted on their behalf. So they can look up and you could see what drug claims a pharmacy has submitted for you. You could look up and see what dental claims a dentist has submitted, either on behalf of yourself or your family. If an employee is submitting a claim, we would reimburse. We have the ability to do electronic funds transfer, again, directly into their bank account. And we've got a significant amount of healthcare providers that we pay directly. About 96% of our pharmacy claims are actually submitted directly from the pharmacy and are paid directly to the pharmacy, which means that member is not going to be out of pocket to pick up their prescription meds. The pharmacy will take that on, and they only would have to pay their co-insurance or deductible if one applies. We also offer a bunch of different tools through our online portal and our mobile app. One is a pharmacy compass, and there are, I don't know if everybody knows this, but depending on what pharmacy you go to, they will charge different prices. They will charge you a different dispensing fee. They could charge you a different markup on the cost of the drug they're doing. So we have built a tool, and it's basically some data analytics of all the claims that we get submitted by the pharmacy. And if you key in your drug identification number and your postal code, we will show you all the pharmacies within a certain radius of where you are and what each pharmacy is charging for that medication, either for their dispensing fee or their drug cost on a per pill basis. We also provide a lookup tool so that if you're looking for a healthcare provider, if they've registered with us, we'll show you which ones are registered and where they are located, again, so that you could access them. We've got a pretty significant, what we call affinity program. We call it our Blue Advantage program. And what it is a group of healthcare providers or services that provide health services that will offer discounts. So for example, we could have lens crafters as part of that, and they may offer 15% discount on glasses. So all our providers do is our members could do is they would look up a provider in that program. They would see, oh geez, I see a lens crafter store, I'm going to go there. They go there, they identify themselves as a Pacific Blue Cross member, and that store will automatically take off a discount from the list price of whatever product or service that they're selling you. We also have the ability, and our plans cover what we call a second medical opinion, so that if you do get a diagnosis and you want a second opinion, we do have a product that, and I'm not even sure, Shannon might know who it's with. Maybe Shannon can chime in. Which company offers that second medical opinion for our service? Do you know, Shannon?
Yeah, so that's through a company called World Care, and they use the Boston Medical Group, the top medical researchers and providers within their network. So we would send, or the member sends their claim or their information, their health history, their imaging down to these top doctors in their specific area of concern. The doctors provide recommendation back to the member's treating doctor. So they may suggest different testing, a different treatment regime, and just provide support for the member's doctor who may not have as much experience with these more rare or challenging conditions.
Thanks, Shannon. Appreciate that. See, I knew Shannon would be able to help me because I've got a good high level understanding, but I don't have all the details of everything we do and offer as well. All of our plans include, and again, we're very conscious that some people may not have the capacity or the capabilities to actually get out and pick up products and services they need. So we do have, many of our pharmacies have home delivery services or even mail order services. And that can be done from we actually have a preferred pharmacy program as well that we have looked at the pharmacies. We've looked at the programs they offer. We've looked at the prices they charge, and we would, if they are reasonable charging mechanisms, as well as a good set of programs, we add them into our preferred pharmacy network. We have a number of local BC companies in there, from London Drugs, Save on Foods. We actually have Safeway, we have Costco, and we also have a number of independent pharmacies who are part of that program as well. We also cover mobile services for physiotherapy and registered massage therapy. And as you can imagine, when COVID hit, and I'm sure as all of you know, we were all in lockdown mode, many people still needed treatment, physio, chiro, and vision. And so we do offer some mobile services as well. Now, we also have the ability through some of our teams to be able to actually send mobile services and training as long to a remote location, but they have to have a bricks and mortar location. They can't just be mobile. Oops. Right, done that one straight. There we go. Okay, so the other thing, and this really falls within sort of the COVID. When COVID hit, we were, I think, in terms of accessing healthcare, we were very used to in certain terms and certain modalities to be able to access those care providers in an in-person setting. And we had to quickly transition to COVID through the colleges that allowed their healthcare providers to offer their services in a virtual setting. So we were able to transition that, and we are now able to capture and share with our plan sponsors what percentage of the services that can be provided virtually are done in a virtual mode versus an in-care mode. And some of the types of services are provided: clinical counseling, psychologists, speech therapists, occupational therapists are all done in virtual. Even some hearing services are done in virtual. Naturopaths and physios and chiros are actually can be done virtually through again, mobile apps or phone calls. And then generally those providers would bill us directly for that virtual service, where they will issue a receipt to the member and the member can make an online claim. We also, as I mentioned before, we have the cognitive behavioral therapy mental health programs available for people. And we also cover employee and family assistance programs. And we use a third-party vendor where employees can confidentially access the services of any type of healthcare professional or counselor or financial assistance, depending on what they need. All of our personal health plans, and when I talk about personal health plans, that is, if I'm an individual member, I live here in British Columbia and I want to buy my own private coverage, Pacific Blue Cross will also sell a plan to an individual themselves so that it could augment their services. And we also have what we call a plan that has been very much designed to be able to help those smaller employers and try to augment all of the services. All of those plans, both the personal health plans and the small group plans, all have access to 24/7 on-demand virtual care. And they can, any of our members can use this app. We use the TELUS solution, and they can connect to a nurse practitioner, a registered social worker, a clinical counselor, a psychologist, and a dietitian to get some of their some of their medical needs met, or even sometimes referrals into other parts of the system. Some of those folks can actually help with prescriptions, lab requisitions, and even provide mental health support and or access even into the registered dietitian. So what we tried to do was realizing that again there is some limited access. If you at least could access it virtually, they could at least get you into hopefully the care with another setting. In terms of again our small and personal plans, we cover ambulatory services, so ambulances, for again emergency situations from a location, and it could include land or air. If they had to fly you, we would also include that. We do cover hospital stays, or if you're in a hospital for care and you need a semi-private or a private room, we will pay for those. And we also cover the cost of nursing care. And again, it's up generally to, we have maximums in those plans, and it's generally nursing care that would be provided in your home. We have, and I think we have had some requests where people want that more, say, in-person care while they're in their local hospital. But if they're hiring a nurse, they actually don't have the ability to provide the same nursing scope of coverage as what you can as a nurse in a home. And that's sort of, I was just trying to give everybody sort of a high level of all the products and services we cover. And I was really interested today in terms of getting your thoughts and input with those of you that are living in rural areas or in small towns. What gaps do you see? That do you have in coverage? Is there anything that we, as Pacific Blue Cross or other private carriers, should be thinking about adding to our plans and our plan designs into the future to make sure that we have the right offerings to be able to meet healthcare needs and to make sure that people want to continue to live in rural and open areas. So really opening it up to the floor as to people's thoughts. And some of the other folks have been on our calls before. I know I think I'd heard that, as an example, many communities and small communities don't have palliative care services like we do in urban centers. Is there a need for that? Travel logistics coverage, that's a good one. Thank you. A very good one. We do have another plan, it's called medical travel. And so we do have some of our plan sponsors that purchase medical travel, and that means that we will pay for someone's trip down. If a physician says that someone needs to get treatment in another center, we will pay for the cost for their trip down, and generally even some cost for someone that might have to travel for them to be with them as a support mechanism when they're away. So that's an add-on type plan that any small employer could add to their package. It is generally what we've seen in our block of business. It is generally the larger employers that add on that medical travel expense benefit. But I also know there's a very good travel expense benefit too offered by the province, that the province also provides that coverage as well. So any other thoughts? Grief and bereavement support, perfect. Okay, great question, Mark. So we do pay for some. So first of all, we know there's the UBC Pharmacy Clinic, which has 50 clinical pharmacists. We have just started a pilot project with one of our plan sponsors, and we have taken, I think it was about 1,400 people out of that plan that were on 15 or more medications, and told them about the services of the clinical pharmacy center and encouraged them to access the services. Now, because of privacy reasons, we are not able to know who accessed those services or what the outcome was. And we're just going to do some high level analytics in terms of the cost of those members. Has their cost gone up or down? It doesn't look like their care regime has changed at all since the time we sent them a letter. And we're going to do that. We're into the first 8 months of it. So we've got about another 8 months to go before we can start the analytic portion. And Lorraine, you have your hand up.
Yeah, I just want to speak to the medical travel plan. Didn't know that you had this. Big news to me. You did comment that the provincial had a great medical travel plan, and I don't want to correct you, but for rural and remote areas, it's not such a great plan because they will only pay for a plane ticket, and it can't be an emergency. It all has to be booked in advance. We don't necessarily have air transport out of where I live. So if I need to go more and more often for everything, yeah, that they don't cover any of that. No, not hotels, not mileage, not food, not anything. So I think that there is room to actually bring in a service that a community could pay for. Like we've done some research in Fort Nelson, and we have sort of roughly figured that our community members are spending about $1.5 million a year for medical travel out of here. And more often we can't get an ambulance to take us, whether that's by road or by air. So we're just hiring our own, or we're just headed down the highway 4 hours to the closest place for medical assistance, but doesn't necessarily mean that they can do everything either. So yeah, I've been trying to work with I've been even to Lloyd's of London to try to get an insurance company that would be willing to take on a community as a whole, fully understanding that, you know, we have to pay for it. But yeah, so if you could expand your offerings on medical travel for our, especially like, as I know you have a definition for rural there, but there's a big difference between a small community that's an hour outside of a larger center and a small community that's 4 hours away from a small center, 8 hours away from a regional, you know, appropriate center. So yeah, that's just kind of what I wanted to add to the conversation.
That's a great add, Lorraine. And it's, you know, as I said, you know, right now what we sell either to individuals or we sell to plan, you know, employers or plan sponsors, unions, or things like that would want to purchase health benefits. I don't know if we cover association, like sometimes people will come together and form an association and will want to purchase a product, and we sell products that way as well. But this is actually a really good takeaway, and Shannon and I will take that into our internal teams to see how that would fit. But
yes, I'm taking lots of notes, and if you're open to us reaching out as we have further questions, that would be wonderful too.
Yeah, absolutely. I'll put my email address in the chat box here and my phone number, and I would more than welcome like further discussion. Absolutely. Thank you.
Thank you.
You know, it's fascinating. You know, I've always lived in an urban center. I've always had, you know, the ability to access care. I'm not saying that I might not have to wait, but I've always had that ability to get to care. And I, you know, many of my family do live in rural and small towns, and I hear stories from them all the time about the difficulties they have, or when, you know, hospitals are closed, and what do they need to do, you know, to be able to access care, how long they have to drive. Lorraine, to your point of what do you do? Now, you know, some of our benefits, like out of province and out of country coverage that we have is definitely, we only pay for emergency situations. Like that's not coverage that's intended for a planned trip to go look at a procedure. That's what we would call more of our medical travel benefit. You know, you need to go get some health services done. You have a referral generally from some healthcare provider that says that you need these types of services, and then we pay for the cost of your trip to get to a place. So slightly different products. You know, from a private insurer perspective, both of those products, the out of province, out of country, and the medical travel, is a fairly, I'll call it a manual benefit, which means you actually have to submit a lot of paperwork and forms, and we have to a lot of, I'll call it manual adjudication to do. We do allow in the medical travel benefit, it could be by bus, train, car, mileage, air, it doesn't really matter, whichever form of transportation that a person would want to take, we do cover all of that as well.
Yeah, and I guess I just wanted to add one more point that when we're lucky enough to get medevaced out, whether that's by ground ambulance or by plane, because it doesn't always happen, I have to tell you, then you're just left there. You got to make your own way home. So if you don't have a credit card, or you don't have room on a credit card, or you're released earlier than my most recent resident got left on a bench for X amount of hours until her husband could get down, and it's cold here now.
Yeah.
But anyways, yes, so all of that travel is on your dime too, and not everybody has room to be able to do that on their credit cards. So yeah, that would be included in the wish list.
We have lots of, as well as providers that will bill us directly, or members that do have the ability to pay and then claim. We have a program which we call assignment of payment. When you need to do something, you can work with the provider. You fill out a form authorizing that provider can bill us on your behalf so that you're not out of pocket. So we've got that mechanism that we can use as a tool to help those, to give that financial capability for. And generally our medical travel benefits do pay for the cost of services, not only to get down to be treated, but also back home again.
Well, that would be humane, wouldn't it?
Yes, it would be. Yes, absolutely.
Thank you. Thank you for your time.
Any other thoughts or products, services? Again, I can't imagine the difficulty that you have in terms of accessing much of this care. I do think we need a different healthcare model that, and some of it I think is technology based, of better supports to be able to allow those healthcare providers to be able to go in, sharing different models with across groups. Yeah, and it was interesting. I know I do some work. We do some work with the First Nations Health Authority on behalf of First Nations people here in BC, and I know they're opening up a primary care center. I think it's in Williams Lake. They're going to be doing their grand opening next week, I believe. And I understand their plans again in these very rural communities and small towns. They're planning on opening up more, I'll say, rural healthcare centers, primary care centers, which I think is interesting and happy. And again, if you are interested, I'm happy to connect this group with someone from there as well.
No,
And Ella, yes, we're a private plan, so we are not connected to government. We are not allowed to provide the same services that government covers. So for example, we cannot we can't violate the Canada Healthcare Act, where we are paying for hospital services or physician services that the provinces are medically required to cover under the Canada Healthcare Act. But we are private, and yes, anyone can purchase either an individual plan, or any small business can purchase a small business plan. We cover lots of the employers that are up in in various communities. We cover West Fraser Mills, which is a lot of the logging, and a lot of their mills are in some of the small towns. So we cover a lot of those types of folks. I think we used to cover Cominco. I'm not sure if we still do, which I know is in a small town. So lots of we cover quite a few of the employers that are outside as well.
And I think, Leza, that I'd be interested in hearing from Luella and Marion as individuals working in this field who live in very, very small communities. But as you say, I mean, to me, it seems like a lot of those additional services that you were talking about that are now available digitally, which I think, very much was needed, because in a lot of the rural areas, of course, we don't have any access to those kind of specialized services in our own communities. And I think it's, to me, it's a lot broader than when you're working, you might think of an employee assistance program, but this is obviously larger than that. And, I think a lot of times, right, it's not necessarily the employee, but the family of the employee who's covered under that plan that would really like to know that those kind of services are available, and may or may not. But I just wonder, Luella or Marion, from that presentation, are there things you've come across where you see needs expressed by your residents that you think could be better met somehow?
From a Pender Island perspective, 55% of our population is over the age of 65. So the technology about virtual visits is somewhat of a barrier on two fronts. One is that many of our individuals, regardless of age, can't afford technology, and so don't access it, or access it in really limited ways, like they might have a phone, but only for texting. And we have very unreliable internet service, and our high-speed internet is slower than Calgary was 10 years ago when I lived there. So it's not high speed. So, and some programs require that kind of dependable service. We have power outages more than we have power on. So that's another barrier. At this time of year, we're into power outage season instead of fall, winter. So that's one thing that I can think of, that it's about relationships and face-to-face conversations and the ability to hear and ask questions and not be stymied by technology. And I really join the others who talk about people getting discharged in the middle of the night and not able to get home. That's absolutely an island issue. Ferries, the last ferry coming this way is at 7 sometimes at night. And so midnight discharges and no funds available to do anything but sit on a bench somewhere till the first ferry at 6 or 7 in the morning. And the difficulty getting from downtown Victoria to the ferry, which is in Sydney. And that's a taxi ride, so, money. And I don't know how insurance plans work with that,
Yeah. Marion, in terms of the technology, and I understand stability of the internet, do they actually have, what's their access of phone service? Because a lot of the virtual care offerings we have, some of them are done, whether it be through the medium of, some of it's Zoom, which again, obviously you would need the technology, but many of the virtual services actually can be done, especially in psychology, and some of those actually just by phone call. Do you have the same issues with even phone coverage in your towns?
If you can talk to a flip phone, you're talking to the right age group here. So yeah, phone service without the visual. And truly flip phones are quite prevalent here. And I think that's an affordability issue as much as it is a resistance to technology. I don't think that's always the case at all. But I think it's about costs. And so that would work fine as long as people can hear well enough on their phone and relax enough to not get anxious about asking the wrong questions or interrupting or those kinds of things. So at the moment, the bulk of our counseling is done virtually. COVID kind of forced that, and many people have stayed in that mode, and it's been by phone, not by Zoom.
And it's just good for us to understand. And as we, I see some questions from Kalita, on First Nations. So we were fortunate enough to be awarded the First Nations Health Authority was created, I think, in 20.
Leza, you're fading in and out a little bit.
Sorry. First Nations Health Authority was created in, I think, in 2013, and with a mandate to create vibrant, self-determining families and improve the health and wellness of First Nations throughout our province. They are, again, a not-for-profit society similar to us. They exist solely for the benefit of the Indigenous people here in BC. Their journey, they have, as you know, all Indigenous people were covered under a federal government program called non-insured health benefits, and provided services for them, dental, prescription drugs, medical equipment, some vision supplies, vision care benefits through that program. And when the First Nations Health Authority was created, they basically took that program and started to run it themselves. And they went through a really unique, I think, engagement series where they actually went out into all of their communities. There are 203 bands here in BC. They went out into their regions. Provinces is divided into a number of regions for them, and they went out into those regions and they connected with the communities to listen to them, to hear what their issues were, to hear what the challenges were in terms of the First Nations folks, one, either accessing care or some of the trust issues that they had with care. And they took that as input into some of the changes that they needed to make to the benefit plan offering that they had. Now, the benefit offering that they had through the federal non-insured health benefits program, I will say was quite administratively burdensome for healthcare providers, which means that if a First Nations person went in there, quite often before a healthcare provider could even treat them, they had a lot of paperwork to fill out, to send in to them, to get approvals, to even treat them, to clean their teeth. So they changed a lot of those administrative rules in the program when we started to administer it, and we have been administering their dental program since 2019, their vision care program, and their medical equipment program since 2019. And we were really honored to launch for them in late 2021, their mental health program. And so they, again, offer various mental health programs for a number for the First Nations population, missing and murdered women, residential school survivors, or members that have been impacted by residential schools, and just other mental health issues. So what they have is providers can register to be, or request approval to be a mental health care provider through First Nations. They register with us. The provider can then treat First Nations. So we've created basically a whole online program, which means a provider can submit a prior authorization saying, I need to provide X number of hours of treatment to this client. We receive that electronically. We can ship that over to First Nations Health Authority. They will look at the data that the provider has sent in. Generally, the First Nations response time on something like that is about 4 to 5 hours, which is transmitted back to the provider. The provider can then generally start treatment within a day or two. That before they were administering it all in paper base, and the average response time was about a month. So we've been able to take something down from a month in terms of accessing and getting care to treatment, about 4 or 5 hours. About 94% of the pre-authorizations and claims that we're getting are all now received electronically as well. So again, and we really focused on not only the access to care, but predominantly reducing the administrative burden for the providers. We did not want them spending time on paperwork and submitting forms. We wanted to make it as easy as possible. And we tried to do as much of the work as we could in the background, through rules and routing things to the right people so that they didn't have to worry about that. So we're very proud and honored. And we, as part of working with First Nations Health Authority, we have really endorsed and our entire workforce has gone through, diversity, inclusion, and equity training. We've gone through the Sanya's health training, which is for cultural safety and humility. So anyone who is potentially either working with a healthcare provider that is serving First Nations, or that could be working with First Nations, all of our staff have completed that course, and we continue to go through all of those unique courses where we know there's a new cultural safety and humility accreditation in the process of being developed, and our plan is to become an accredited organization in that area as well.
That's very interesting, Leza. I was just thinking too, to point out, since this is Blae's first meeting, Blae, could you just take a minute? I mean, I think a lot of us wouldn't necessarily know that over the last couple of years, there's been a lot of sort of legal decisions made, and certainly the Métis Nation increasingly is looking at many of these things as well. Did you want to take maybe 5 minutes, Blae, and just sort of talk about Métis Council and future plans?
Sure. In terms of future plans, it's interesting. We talk to people in our engagement sessions, and there is this expressed desire to have a Métis version of FNHA, to have Métis clinics, Métis practitioners, increase Métis participation in enrollment in post-secondary programs related to healthcare and healthcare delivery. It's something that's always on the radar. Healthcare is of course always right on right up there with topics that our citizens want to engage the government with. And this being my first meeting, I was considering the needs of our citizens that live in rural and remote communities in BC. Métis are 3 to 3.5 times more likely to live in a rural and remote community than non-Métis British Columbians. And we hear a lot of things that have already been echoed by some of my new friends here with regards to travel is a significant barrier. And then mental health is actually something that's been quite pressing on our agenda. And so we've come up with a program actually called the Métis Counseling Connect program, which we provide funding for 10 one-hour sessions with a registered practitioner for our citizens. And that's to get the ball rolling with them connected to culturally competent and safe practitioners, and also give them access to traditional health and healing and traditional ways of knowing. I think that that's something that is really hard to decolonize in the health benefits arena. Putting my full hand forward, I used to work for Alberta BlueCross as a business intelligence advisor for their government affairs department, and I got a little bit of insight into how the sausage is made. And I understand that there's a lot of complexities and a lot of moving parts. But what would be really nice, I think, what would mean the most to Métis citizens and MNBC generally, is to see space made for that traditional health and healing and ways of knowing, to see space for Métis people to see themselves in the system. As it is currently, it's modeled, as we all know, very heavily on a Western based model. It's very heavily Westernized with a focus on treating symptoms and not always getting to the root causes and sort of the holistic approach to health that Métis identify with. And so connecting people to culturally safe and competent healthcare practitioners in their, within reach of their communities is a huge step in the right direction. Yeah, we're a growing nation. We've got 23,000 registered citizens. Métis make up a third of British Columbia's Indigenous population. And so we're not going anywhere. And as my manager likes to say, we're BC's best kept secret. And as we gain momentum and as we build these relationships and attend these meetings as we are today, I just really wanted to express my gratitude as well for being able to have this opportunity to share that with you and to feel heard. I think that we as a group all come with so much different experience and understanding of these issues. And I see heads nodding as I bring up one thing or another. So I know I'm not alone. And we just want to see this move forward in a way that Métis people can see themselves reflected in the plans that are offered, reflected in the products and services that are available, as they do comprise, quite a few of our rural and remote British Columbians. So, yeah, I don't know if that touched on what you were hoping for, Gordon, but that's what I've got for you.
Exactly. No, thanks very much, Blay. That really helps. And as you say, I mean, I think too, just as you say, your experience too of in a different province, that is also rural, right? With two great big urban areas and the surrounding little communities. And I guess, really a bunch of other sort of, I guess I would call them second tier as far as size, like the Red Deer and the Grand Prairies of the world that are, still very large, right? Damn near 100,000. But I think you're right, is that sort of for rural people, just that access, as you say, to appropriate information. And that's one of the things I'm not sure it's maybe good that I think Dr. Markham left. I was going to say, maybe he could correct me. The other thing I was really fascinated about that you mentioned, Leza, was the second opinion availability for some members. And I think, again, that maybe other people would correct me if I'm wrong, but I'm thinking, again, I'm very fortunate we have a family doc, but a lot of people don't. And I think in a lot of cases in rural communities, people will either be in an emergency department, they're treated for something, the emergency department wants to get them out of there. So they're basically saying, look, you're not going to die tonight. You do need to get checked. We think it's something like this, and give them a referral to a specialist. And then they're sent home. And then they've got to arrange to, as we talk about, all the hassles of trying to travel to find this specialist at some point. Or they may be treated with a locum that they'll never see again. And I think a lot of times, right, if depending on what they're being told, they may be in, you know, it's kind of in one ear, out the other, or they're not sure what the doctor said. And I think that, you know, it'd be really interesting that I think a lot of people probably don't know that service is available. But I think that a lot of people probably would be interested in using that, because I think it would just give them a little more feeling of safety that somebody else has looked at this who's actually a specialist in that field. And, you know, again, because even the specialists they may see in BC may not spend a lot of time with them just because they're busy, right? So, but I don't know if anybody else.
Shannon, I don't know if you have any stats. I'm probably putting Shannon on the spot here because I know she is in our product area, and but I know she's really smart too, and she always follows up on a lot of these products and how the models work. So I don't know if you could add anything more to our second medical opinion. I can share with you that when we launched our virtual care product, that gives access to nurse practitioners, dietitians, and things like that. We had originally launched it, and one of the vendors we were using, we were able to do it, access a doctor through that.
Oh, Leza, you're fading in and out again.
Sorry, you were able. I don't know what's with my camera. Some days it works, some days it doesn't. It must be a day that's not working today. When we originally launched our virtual care model, we were able to allow our members to actually access physicians as well. Unfortunately, we've got some restraints and constraints in our regulations that GPs were not allowed to be able to provide that service as well as be in the public system and all throughout the Canada Healthcare Act. So now it is limited to those types of healthcare providers, nurse practitioners, and psychologists. But would love to, I actually see the virtual model, whether it be second opinion, virtual care, I see it being as a model that's going to be absolutely necessary for us for access to primary care into the future. And I'm hoping our province can figure out what's the best way to do that, and what stakeholders can they work with to help provide the right accesses for it as well.
Thanks, Leza. Luella, was there anything you wanted to sort of mention or bring up?
Well, we're a small town too, so we travel mostly to Vernon or Kelowna, and that's about probably 3 hours to 3.5 to 4 hours to Kelowna. And transportation is always a big thing too. We do have a medical bus that used to run every Wednesday, and now because of funding, it's going every other Wednesday. So, you know, that makes it more difficult. And then we have a community bus that does go to Nelson. It was once a week. I'm not sure, maybe it was twice a week. I'm not sure if it's once a week now. So people try to work with that, but it is hard to get medical appointments on the right days and the right times. And then, you know, if people are too sick, then that's a long drive, for them on the bus. And then we have run into where people have had appointments like to Vancouver, which would be, you know, by air, and that's like an 8-9 hour drive. So at this point, I don't think there's any funding available for that. There used to be one at one time years ago, but I'm not sure anymore. And yeah, so we do have community paramedics, which is really good. And they're good about going into the homes and good communication with them. And we recently have had a social worker be hired at our medical office in town. And she's really good. So she goes to the seniors' homes, people that need it, and tries to help them that way. And again, she's really good about communicating. So we're lucky in that way. And we do have I believe we have 3 doctors, and we have locums that come in pretty regular too. So I think now most people would have a doctor now, which, you know, there was a time where some people didn't have doctors. But, you know, there's still, you know, where lots of times where you have to go see a locum, even if you have a family doctor. And, you know, the same thing is there's lots of, you know, trips back and forth, you know, if you're cancer, chemo, that kind of thing, which is very expensive. And yeah, and they've done phone calls, especially through COVID, and they're still doing that to a point. So that helps, but you know, same thing. It's, you know, is whether the people are comfortable asking the right questions and technically inclined to handle it and all of that kind of stuff. But overall, I think the cusp is pretty good for where we are. We still have our hospital. I believe the hospital, like just down from us, was closed. So now it's just not assisted living, but living, senior fully assisted living. So yeah, so overall, I think we're doing pretty good, but you know, it always could get better, and especially with the transportation.
Yeah, thanks, Lavelle. Very much the same. I'm just thinking, I'm not sure, Pablita, I know in the text box, and I'm not sure if we actually got to it. I think both you and Mark had mentioned maybe something about on the bereavement. Did you want to follow up on that, Mark or Pablita? Either one.
Go ahead, Poppy. I mean, to me, it's your territory, right?
No, it's okay. No, our work crosses paths, so sometimes I got to look at him like, okay, is he going? So I guess in for grief and bereavement, I know that obviously in light of COVID, access to psychosocial support and grief support has increased, and the complexities of grief has definitely changed. The landscape has changed, and in saying that, when we did our grief and bereavement report earlier this year, we did see that a lot of the new cases of grief support that came from the communities, the majority of them came from the rural and remote communities. But also one could argue that 63% of the hospices that serve BC serve rural and remote communities as well. So, you know, but when we looked at the demographic, we did see a lot of shift in who was accessing grief and bereavement care at our societies. And it wasn't those that were accessing hospice care. It was simply for the grief and bereavement services. So that's just been something that we've tried to take the lead on in terms of community support grief and bereavement. If that means, you know, it's paid counseling support, psychosocial therapist support. But I just wanted to know if you guys have seen a shift, perhaps, in terms of the increase in claims going through for support. I know that the government has been talking about publicly funding counseling services, but for mild to moderate. But I just wanted to get a sense of if there's been any discussion on an insurer standpoint in maybe expanding the scope and expanding the amount of claims that can go through for counseling services. Oh, I think Leza, you're
on.
Great question. So yes, we are always, so quite often when a plan sponsor takes out coverage, they can be, you know, as I said, they can be quite specific in terms of what types of healthcare providers they offer. And specifically in the mental health, we still have some plan sponsors that are, again, they'll say constrained. It's got to be through a psychologist, or it's got to be through a social worker with a master's degree, and very specific designations that people would need to be able to access. We realize that, and we've seen an uptake not only in mental health services, especially since COVID, but even in the mental health drugs. We've seen, I think it's about a 15% increase in mental health drugs since COVID as well. So we are very much advocating to a number of are folks that provide benefits to, whether it be their employees or we cover a number of retirees throughout the province as well, of looking to try and expand their definitions of the healthcare providers that they would cover. Specifically into clinical counselors. It is a bit easier sometimes to get into a clinical counselor than it is to a psychologist. I'd love to learn more about, is there any other healthcare providers that we should be considering? And then how are they accredited and recognized, or what type is, how do we know that someone has got the capabilities to provide the help that someone needs? So I believe if there's anything that you could provide us, we would love to learn more about that, especially in some of those professions that are not regulated yet.
Yeah, absolutely. We're actually having on the 27th and 28th, tomorrow and Friday, our workshops on complicated and complexities of grief. And there is a topic and discussion about that in terms of broadening the scope of care and deliveries for non-regulated and regulated psychosocial and grief support. So I will send you that that recording when it's done, because I think it's going to be a very engaging session. And there's going to, we have a very good mix attending this 2-day event, actually sold out. And this session is one of the sessions that is highly attending. So I think absolutely, if you're ever needing some additional information, and there are other provincial organizations that we work with like, say, for example, the BC Bereavement Helpline, which is a fantastic organization. We work alongside with them very much so when it comes to data and program supports and things like that. So more than happy to provide that.
Oh, thank you. That'd be very much appreciated, because again, we're always looking to see what is needed and where should we be going next. And quite often, again, as you can imagine, when you enter into a contract with a plan sponsor, and we still have to get their approval to expand coverage. And, as you can all imagine, if you expand coverage, costs go up, therefore their premiums go up. So they've got to factor all that into budgets as well. But we take a lot of pride in terms of working in partners with plan sponsors and our members in trying to provide them the care they need at the time they need it.
Oops, sorry, Lorraine, did you so you got your hand up, or is that from before?
No, I put it up again. Just wanted to speak to that professional designation piece, whether it's bereavement or massage therapy is the one that I would like to address. So there's a 2-year program out of Alberta, and there's a 3-year program out of BC. So where I reside, most of our massage therapists, except for one, and she's like 85, so she'll be retiring anytime soon. All the rest of them, because we're closer to Grand Prairie than anywhere else for training, have the 2-year designate, which BlueCross doesn't cover. Because if you live in Alberta, they cover the 2-year program, but I live in BC, so they only cover the 3-year designate, right? So I'm grateful that the person that carries my insurance, so I'm an elected official, so it's the town of Fort Nelson that provides me with Pacific Blue Cross insurance, and Pacific Blue Cross has made is flexible in the 2-3 year, but they're not for everybody. It just so happens. I think that this is something you need to look at. I also want to congratulate Pacific Blue Cross in that, because we don't have physiotherapy in our community, they have given us a few more chiropractic visits to be covered. So that's really helpful too, but just for us. So if that could be looked at being expanded to rural and remote where our services are not available, like a few more chiropractic visits are really helpful, and looking at that 2-year designate for massage therapy as opposed to 3, depending on the province you work. So just want to get that.
That's all, a great feedback. Thank you, Lorraine. I would love, and one of the things I talk about all the time is the disparity in healthcare, even across Canada, and the challenges. And, one of, every province is different in how they regulate healthcare providers, right? And so, to your point, a massage therapist. We have a college of massage therapists. You have to be accredited, you know, you've got to be registered with the college to be able to practice massage therapy here in this province. And that's part of the challenge that I'm always encouraging, you know, the colleges and the regulators across the country to try and harmonize and agree. Like, we still have some, you know, some provinces that have no regulations on some of these professions. And that's where it comes in. You know, is it a 1-year program, a 2-year program? And that's where a lot of the differences come in. And so, you know, I don't know what ability we as a group have to be able to promote and advocate for that, but it's one of the things I see. And I know the Health Professions Act is actually right now before the provincial government. They're changing it to harmonize the 24 colleges, I believe, down to 6. I don't know how long that will take, but we've got to now start to understand what are the takes. So, you know, when we go through an accreditation process we have to make sure that that provider, that healthcare provider is accredited in the province that they're providing the service, right? There's some risks that everybody is bearing as a result of some of those, I'll say, openings that we have allowed. You know, not only, you know, you as a patient, but the healthcare provider is actually taking a risk as well.
Oops, so maybe I shouldn't have said that.
It's okay. It's okay.
Okay,
It's quite all
stop that recording. Forget you heard that. I don't want to mess it up.
Yeah, make sure you edit that part out, Sarah. Yeah. No good deed shall go unpunished.
Always, right? I always put my foot in it.
Well, folks, we're a little over 5 minutes over, and I know some people do have to go. I thank you, Leza and Shannon. I think that was a great presentation. Really appreciate it. Just so folks know what our plan is for November, we're just waiting to try to set a date. It'll be either the end of November, first week of December. We're trying to track down a couple of guest speakers. The last call we had around the personal health records, there was that discussion about the fact that apparently when we lose our family physician, that the healthcare records go somewhere. So what we're doing is trying to get a guest speaker who can tell us, okay, where do they go and how do I access them? And how do I, if somebody doesn't take over my doctor's family practice and somebody else is treating me, how do I know that they have access to my full health records? We thought that might be of real general interest. So we're going to do it as just an open webinar. So this group would be invited as well as just members of the general public, because we think there's a fair amount of interest in that. And then if any of you have any ideas about other topics you'd really like to see us discuss, please let me know, and we'll try to cover them in the coming months as well. And then just the last thing, I'd just like kind of follow up on something that Lorraine said, Leza and Shannon, because I really do think it's a need, is that, again, of those stats, right, that the majority of, you know, there's still a significant population in rural BC, and it is a much older population, so a much higher percentage of retirees. And, you know, some of us are fortunate enough that because we had employers and we were covered under an employer plan, even when we retired, we were covered under a plan. But there's a vast majority of our senior population that wouldn't have any access to plan. And I'm not sure they can afford individual plans. But when you mentioned, Leza, any kind of association, or as Lorraine was talking about, you know, at a community level somehow, I think then becomes much, much more affordable. And I think there would be some interest among some rural residents to be able to access some of those services. So
yeah, I'm definitely not a lawyer, or how people are allowed to form. I know people are not allowed to form associations only for the sole purpose of gaining insurance. I know that, but there are lots of associations out there that actually already exist for a whole lot of other services. Like I think there's the Canadian Association of Retired People as one, right? Exactly. Again, I don't know all of the services that they offer, but that might be an avenue, that an association like that. But I love the idea of the community association, because to me, and again, I'm not a lawyer or legal representative of how do you form an association, what are the, the fees and the exercises to do it, and then what kind of services could that community association then start to benefit the community? Maybe it's access to private health benefits. maybe it's negotiating with internet providers for more stability, in internet. So, I could see a whole range of benefits that a small community association could actually, I'll say, maybe have a stronger voice than one or two, people from that resident. So, again, I don't know much about it, but maybe I'll ask our lawyer at work about what do they know about it. And again, I don't know if that's their expertise, but definitely we'll ask some questions on it for sure. And I know Shannon has got that as a takeaway for us to see what could we do if a community did want to do something and just want to buy benefits through a community group, because I see that being a need into the future. I really do.
Yeah. Well, great.
I know everybody has to go, but I would really advise you to get in touch with the Municipal Insurance Association, because most, not all, but most communities in BC get their insurance from them. And I tried to get them to take on the travel insurance piece, which I was unsuccessful, but you might have a little bit more power than me. So that might be a
Okay.
suite of services that they could offer that you could provide, but they could be that middle person that connects all of BC with that.
Okay. Yeah, I know we provide coverage for the UBCM, which is the Union of British Columbia Municipalities. So we provide their association, and then we provide their benefit coverage for them for any municipalities or cities or towns that want to buy, but that's generally for people that are in the government of that town. Is that?
Yeah, it's just how I'm covered, but it, like, for us to get our liability insurance and all of that, that all goes through the Municipal Insurance Association. So
Okay.
that would be an
We'll do
organization.
some research on that and see what we can find out.
Thank you.
Yeah,
Great
great
insight.
points, Lorraine.
Mhm.
Well, thanks very much, folks. I hope everybody stays warm and dry. and yeah, we'll let you know as soon as we can nail down these guest speakers for the November/first week in December date.
Looking forward to it.
All right. Thanks very much, guys.
Oh.
Take care. Bye.